Good morning, everyone. It really gives me a great joy to introduce the speaker for Grand Mountain today. Today's speaker is Dr. Ghali. He's our new recruit. He joined us in August last year from Fred Hutch. So he's a urologic oncologist who specializes in taking care of patients with bladder and the urinary tract cancers and also testis cancer as well. He finished his medical school at Geisel School of Medicine at Dartmouth. He then wanted to, UC San Diego for his surgical internship and residency. And then he went on to University of Washington in Seattle for his Society of Urologic Oncology Fellowship. And then he joined us as a faculty last August. His research interests include designing clinical trials and biomarker development in urinary tract cancers. And he has received multiple awards and grants and publications. Dr. Ghali, the floor is yours.
Great. Thank you all for being here. It's really an honor to get to speak with all of you. Like Dr. Kim has said, I started just about 3 months ago, so this is early in my stay here at Yale. But it's really been such a pleasure to meet all of the other faculty and get to take care of patients with you all. So thanks for having me. I'm going to speak today about biomarkers within bladder cancer, and this is sort of this is a broad title, and it's a bit of an ambitious maybe title. So I think what's maybe more appropriate is examples of biomarkers within bladder cancer, and I'll sort of weave in a little bit of overview of how we take care of these patients, talk about some of the work that we've done and some of the work that's ongoing that's exciting. Disclosures, none that are relevant here and none that are ongoing. And so, like I say, we'll sort of talk briefly about an introduction to bladder cancer patients and care. We'll talk about non-muscle invasive bladder cancer, which is sort of the early part of the natural history of the disease, talk about advanced bladder cancer and some of the ongoing clinical trials, and then hopefully have some questions, some time for questions at the conclusion. So to start, bladder cancer is a common and unfortunately lethal illness. It affects about 82,000 Americans per year, and approximately 17,000 Americans succumb to the disease. So fifth or sixth most common cause of cancer death, depending on the gender of the patient. And the majority of patients that they experience bladder cancer are in Medicare age, so sort of 65 years of age and older. So you can see here from some SEER data that approximately 80 to 85% of patients with bladder cancer are elderly, and those are the patients that bear the brunt of the mortality of bladder cancer as well. And so this is really a disease that affects primarily the elderly patients, although of course not exclusively. 3/4 of patients that present with bladder cancer, however, do present in an early stage of the disease, what we call non-muscle invasive. And so you can see in this schematic, which I am using here without permission, so hopefully that's okay. But this is a schematic from the internet, and shows, you could see that tumors in most patients present in a fairly superficial stage of the disease, where either the mucosa or the lamina propria are involved, but not the deeper muscle layer of the bladder. And this is really a distinct clinical entity, because we can often treat these patients with bladder preserving modalities. So these patients can be treated with endoscopic resections of the tumor and then intravesical therapy. So we can actually instill a catheter in the bladder and give either immunotherapy in the form of BCG or chemotherapies in the bladder and preserve their bladder in this early stage of the disease. Unfortunately, though, recurrences are very common. Bladder cancer has especially non-muscle invasive bladder cancer has a very high recurrence rate. So this is a study from the University of Miami, Rich et al. And it's a really well-done study. It's approximately 500 patients that they've taken care of with really meticulous data review. And these patients were stratified into risk strata that we use in non-muscle invasive bladder cancer, and they tracked progression despite standard of care therapy. And what you can see here is progression-free survival, or recurrence-free survival, I should say, rather than progression, is pretty significant. The very top line here, the black line, is low-risk patients. And you could see after a few years, approximately half of them will have experienced a recurrence in the bladder requiring repeat surgery and so on. High-risk patients have even higher recurrence rates in this series, pretty significant rates of recurrence. So to deal with this, one of the things we do is we put patients on long-term surveillance of their bladder cancer, and this is done through routine cystoscopy. And I like this image because it makes me feel uncomfortable when I look at it. It sort of highlights, I think, the discomfort that patients experience undergoing this procedure. And cystoscopy is really a useful tool in urology, but it's got major limitations. For one, it's not perfect. It has, approximately a 70 to 80% sensitivity for bladder cancer recurrence, depending on the series that's looked at it. It's uncomfortable. Approximately 30 to 35% of patients report experiencing significant anxieties from cystoscopy, and it's expensive. So here are a couple of references that we won't go into, but these are references that really highlight the significant cost to the healthcare system for long-term surveillance of bladder cancer, making it one of the most expensive cancers to care for. And so for those reasons, I think there are lots of reasons why we sort of, you could see I made my own figures here, but you could see that there's a real strong indication for biomarkers in the non-muscle invasive bladder cancer space. Ideally, a sensitive and specific marker that can identify non-invasively when patients have recurred with bladder cancer. There are ones that we use currently. So cytology is a commonly used urinary biomarker. And again, without sort of going too much into it, cytology has its own major limitations. For one, it's quite intensive. It requires a cytopathologist to review. There's significant inter-reader variability between cytopathologists. And on top of that, it's despite being labor intensive, the performance of cytology is quite lacking. Sensitivities have been reported in the 50s to 60% in all comers with bladder cancer, and then obviously substratifying, we get a little more granularity. There are other biomarkers that have been reported, and I'm going to just sort of show you a list of what's been out there. There are protein-based biomarkers, cell-based biomarkers, and in the interest of time, what I would say is none of them are recommended for routine use or certainly for replacement of cystoscopy because of poor performance of these relative to cystoscopies. One real avenue that's come to light in the last several years, especially with the advent of widespread next-generation sequencing, is the question about urinary tumor-associated DNA as a biomarker. And so I'm going to spend just a few minutes talking about this. This has been reported as a proof of principle in several reports. And so there are versions that have been tested in the past. And the proof of principle does demonstrate that it's a useful tool. There are sensitivities sometimes in the high 80s, mid to high 80s for urinary DNA biomarkers, especially in a tumor-informed mechanism for it. But ultimately, the sensitivities and specificities don't seem to be good enough to replace cystoscopy with current DNA sequencing technologies. And one of the reasons for this is some inherent limitations with next-generation sequencing. So I'm going to talk just a little bit about that. This is a paper, it's a little bit old now, but it's a nice paper because it reviews some various platforms. I'm not going to go through in detail all of this, but what you can see here in this column is actually just various sequencing platforms here and the error rates associated with polymerase amplifications. And what you can see is error rates just from the amplification process of next-generation sequencing can vary based on the platform, but can be somewhere between 0.01 to 1% amplification error rates. Which is not significant if you're checking for somatic mutations or really high volume mutations in a tumor. But it can be a problem if you're looking for heterogeneous, low, really infrequent mutations in something like a dilute sample, like like a urine sample. And so one example of, I think, a helpful figure for me is if you look at this sort of 100-well image here, and you could see that we know tumors are heterogeneous. They present they have different populations with different expressions of tumor-associated DNAs. And if you look at standard next-generation sequencing with the known error rates, what you can see is that a lot of the heterogeneity is missed. There are certain subpopulations that can't be captured very effectively. And there are tools to get around this. We can do microdissection, for example, and then do next-generation sequencing, which adds a little bit of labor. It has difficulty with scalability and maybe capture some of these populations. But again, some of the heterogeneity is missed. What about single cell sequencing? And again, single cell next generation sequencing is really effective at capturing rare events, but scalability becomes an issue. And when one zooms out and thinks about the challenge that faces detecting tumor DNA in the urine, the picture starts to look a little bit more like this, where we're trying to capture very, very, very rare events in quite dilute solutions. And this really can limit the sensitivity of an assay, and I think that's what's been shown in previous attempts at this. One thing we've been looking at that we looked at the University of Washington and are trying to develop is using a tool called duplex sequencing, which was new to me as a fellow. It was developed in the labs at the University of Washington with Scott Kennedy and colleagues. And this is a tool that's really helpful for the detection of ultra rare mutations with quite high accuracy. The reason this is helpful is because of a computational tool. Duplex sequencing is primarily a computational tool, which starts off by using a sort of standard error corrected next generation sequencing tools. So, the DNA from specimens are fragmented. We use a unique molecular identifier that's ligated to the fragments. And then next generation sequencing is performed. And if you could see here in this panel, there's a true mutation demonstrated here in green. And then as amplification occurs, there are amplification errors that accumulate in various amplicons. And sort of a standard pathway would be to perform single strand consensus, so that if all of the amplicons don't have a demonstrated mutation, that mutation is sort of assumed to be an amplification error. The technology here is using the inherent complementarity of DNA to identify double-strand consensus, so that even early mutations, even founder mutations in the amplification process, can be identified and sort of deleted out of the final analysis. And so only true mutations, even very rare mutations, are identified. And this has been reported on several times, and it moves the error rate from 1 in 100 to 1 in 1,000 to 1 in 10,000 in some series of standard next generation sequencing to something like 1 in 10 to the 7th. So it really adds quite a significant amount of accuracy. So how have we used this? I think the next step for us was, if we're going to try to apply this technology to a surveillance program for bladder cancer patients, what genes are we going to look for? Luckily, there have been a couple of publicly available and published series that have sequenced very large number, or not very large numbers, but large numbers of bladder cancer tumors. So this is the TCGA, which was published and updated several times, most recently in 2018. This is a series from Memorial Sloan Kettering, which has sequenced some non-muscle invasive tumors. And some of the frequently mutated genes were sort of analyzed from these data, and we came up with a list of some pretty frequent genes, and you all will recognize many of these genes here. So the basic approach that we took to developing at least the preliminary data for our surveillance study was, patients present with a mass or hematuria. They undergo transurethral resection of bladder tumor. And then after the diagnosis is made, a urine sample is taken immediately or soon after surgery. They receive therapy intravesically, and then a urine sample is taken after their therapy. And then patients undergo cystoscopic surveillance. And the goal of this was to just understand, one, are we able to reliably detect tumor-associated genes? And two, do the levels of these tumor-associated genes relate to their risk of recurrence moving forward? So I'm going to show you some examples. This is quite early work, but I'd like to show you some examples that got us excited about this. This is data from a 77-year-old male who presented to us with high-grade T1 bladder cancer with no CIS. And this is just an analysis of their pre and post urine for the 10 genes that we analyzed. It's important to note here that this is a tumor-naive approach, so we're not sequencing the initial tumor and then going on to try to detect these lesions. This is an off-the-shelf approach, which I think is really useful for scalability in a setting like this. And what you can see is the blue is the levels of the variants detected for the common genes that we're detecting. The blue is before, and the orange, which is really almost difficult to see, is the after treatment. And I'll just get your attention here to the y-axis, and you could see that these are very, very rare events. These variant allele fractions are really quite low. A common variant allele fraction for previously reported assays would be 0.3 to 0.5. And so we're detecting really low levels. And what you can see here is that there's clearly some dynamics at play here. And this is the total variant allele fraction. And you can see that this patient had a significant reduction in the total amount of detectable tumor-associated DNA. And they're now 18 months out, no recurrence. And you can sort of contrast that with this patient who had quite low levels at the beginning. After surveillance, after therapy, we were able to detect low levels of STAC2, ARID1A, and quite significant levels of PIK3CA. And this is sort of demonstrated here, really driven by this PIK3CA mutation. And ultimately, the patient in about 6.5 months later was found to have a detectable recurrence on cystoscopy. Obviously, these are specific examples that sort of just demonstrated this was feasible. And so we have now collected a total of 50 patients and are working through the data now. This is just a heat map showing some of their demographic and pathologic data. And approximately 20 of them have experienced recurrences. And the future of this is we're now working through their clinical outcomes and trying to understand if we can reliably identify a lead time for identifying these patients. And so the future of this is we're working through the data now, trying to develop a reliable way to detect treatment response, identify recurrences before they're grossly visible, and maybe identify patients for whom early switching of therapy before a visible tumor is identified, and maybe be able to spare those patients subsequent surgery, for example, if we switch early. And I just wanted to highlight Jonathan Wright, who's a bladder cancer surgeon and researcher at the University of Washington, who's my mentor and developed this project with me, and Scott Kennedy, of course, who was part of the development of this technology. And Dr. Blaha is a biostatistician here at Yale, who, as soon as I got here, I was lucky enough to get to meet him and recruited him to work on this project with us. So have been really looking forward to this. And as we analyze this data, the goal will be to develop a larger study where we can collect ongoing urines with every cystoscopy and hopefully be able to monitor these patients more longitudinally. I think that data will be richer. So we're preparing this analysis now for hopefully some extramural funding in the spring. The thing that we're all trying to prevent is progression of these patients, because progressing to muscle invasive bladder cancer is almost it's an entirely really a different kind of clinical entity, and it's has significantly poor outcomes associated with it. So this is that same paper that I showed you earlier, those same 400 patients, and this is now progression rather than recurrence. And you could see that low-risk patients have a pretty low risk of progression, but high-risk patients especially do progress significantly, and many of them will progress to, like I say, this muscle-invasive bladder cancer phase, invading the muscle or fat or onward. And for those patients, therapy really does transition. Standard of care therapy really transitions from the bladder, the less invasive endoscopic approaches to therapy to often much more involved therapy. So I'll talk briefly about that. The management of muscle invasive bladder cancer generally falls into two broad categories for patients who are candidates for radical treatment. The first is radical surgery, radical cystectomy with lymph node dissection, preceded by neoadjuvant chemotherapy. And the other is what we call trimodal therapy, which is the first mode is maximal endoscopic resection, followed by chemoradiation. So those are the three modes. Outcomes are significantly poorer for patients with muscle invasive bladder cancer. This is a study that looked at data from the VA of all places. These are Vinci data from the University of California in San Diego. And these are multiple thousands of patients. And you could see overall survival plots for radical cystectomy with chemo, radical cystectomy without neoadjuvant chemotherapy are demonstrated here in the dashed orange and the dark blue line. And trimodal therapy with preferred chemotherapy regimens up here. And you can see that survival is at best, at least from these real world data and admittedly somewhat sicker patients, are somewhere in the 45 to 55% range in the 5-year survival data that they report here. This varies a little bit based on, some other factors, but that's what's reported here. One thing to note is that trimodal therapy with non-preferred regimens in these data show a significantly poorer outcome that they were able to detect as statistically significant. So for many decades now, management of muscle invasive bladder cancer has the central feature of it in the United States, at least, has been radical cystectomy with lymph node dissection. We have learned in the last several decades that chemotherapy prior to radical surgery does improve overall survival. This was first shown with level 1 evidence in a study in 2003, which administered MVAC prior to radical cystectomy in locally advanced muscle invasive bladder cancer, and demonstrated about a 5% overall survival benefit. So you can see that's that top line here, and the charts separate. Despite these data, there are good real-world data that we do not use chemotherapy in the neoadjuvant setting very frequently, or as frequently as we should. So this is a study looking at SEER data. It's now a little bit old because it stopped in 2011. And we could see sort of a trend upwards in the use of neoadjuvant chemotherapy with muscle-invasive bladder cancer, but it peaks at around, in this data here, about around 23 to 25%. More recent data using the National Cancer Database reported that while, again, it's still increasing the use of neoadjuvant chemotherapy, the highest that they were able to detect was in the 35% range. And so we're not using it nearly as frequently as we could be. And this is a potential real opportunity for improving survival without major new interventions, without major new, all of the new fancy drugs that we have. This is tried and true, and we just are not very effective at implementing it. What about radiation? And similarly, there is high-quality data that suggests that chemotherapy with radiation does improve outcomes for muscle-invasive bladder cancer. This is the study from 2012, James et al., but there are several others that have also demonstrated that chemotherapy administered with radiotherapy improves at least local regional control. And this is an overall survival plot that wasn't statistically significant, but you could see that chemoradiotherapy outperforms radiotherapy alone, at least in local regional control, if not both. Are we doing better with administering chemotherapy with radiation? We're doing better. We looked at this using the SEER Medicare data set. We looked at a cohort of about 2,200 patients, and the kind of summary of this data, the data that we found, is that in 2,200 patients with muscle-invasive bladder cancer with undergoing curative intent radiation, approximately 40% of patients do not receive any radiotherapy in the time that they're receiving radiation. So again, a significant opportunity for improving care for these folks. Similarly, about 20 to 25% of patients are receiving what we would call non-preferred chemotherapeutic regimens, like carboplatin or docetaxel alone. And these are therapies that there are good data that they do not perform quite as well as cisplatin, for example, in this setting. And so again, this is just an opportunity for improvement in patients undergoing radiation therapy. This is a chart over time. We're getting better at administering therapy, but it's not significantly better in terms of preferred regimens. And we did detect a difference in overall survival in these patients, although I should note that level 1 evidence doesn't demonstrate a clear survival benefit, mostly local regional, but we did see an overall survival benefit in these retrospective data. For patients undergoing bladder sparing therapy or radical cystectomy for muscle-invasive bladder cancer, the goal would be to also expand the idea of, does urinary DNA play a role in for these patients as well? Establishing the utility of urinary DNA as a biomarker in muscle-invasive bladder cancer could play a role in predicting complete response after neoadjuvant chemotherapy, which I didn't show you data for, but is known to be a good marker for a good outcome for these patients. And there's more and more interest in trying to avoid radical surgery in patients that respond to neoadjuvant chemotherapy. For those that are not responding well, there's a question of, would they benefit from expedited surgery or switching therapy? And we don't know the answer to that because we've not had a good marker for assessing it. Currently, we just use cross-sectional imaging, which has a lot of limitations, unfortunately. And then, of course, for those who retain their bladder, there's a question of whether or not a highly sensitive marker could be useful for monitoring and surveilling patients that underwent trimodal therapy. And so these are questions that we hope to interrogate. In the future, we have about 20 patients that have muscle invasive bladder cancer before and after chemotherapy that have undergone radical cystectomy. So we're hoping to look into that at a small scale in the near future. And ultimately, the urinary DNA biomarker has to be integrated with broader, with other biomarkers that are in development. So that would be another goal, is to understand how it relates to other biomarkers. So I did want to talk about one other biomarker, which is not probably new to most of you, as it's made quite a splash in a lot of different cancers, but I'm going to talk about its role in bladder cancer, is circulating tumor DNA in bladder cancer. This is also a very exciting area of our in this field in bladder cancer, and it sort of started, at least has come to the forefront in the setting of another clinical trial. This was a trial published in 2021, the use of adjuvant atezolizumab for folks who have bladder cancer, to try to reduce disease, basically increase disease-free survival in these folks. So these are high-risk folks that had disease on final pathology after cystectomy, and they were randomized to receipt of a checkpoint inhibitor, atezolizumab. And this trial, unfortunately, ultimately was a negative trial. It didn't show an improvement in disease-free survival. But one subsequent study that resulted from analysis of these data was reanalyzing the clinical data based on substrata for circulating tumor DNA positivity. And so I'm going to show you some of the data from this paper published in Nature in 2021, May 2021. You could see here that the data are stratified by observation in the orange versus in the blue, receipt of atezolizumab in the adjuvant setting, and circulating tumor DNA negative up top and circulating tumor DNA positive below. And one thing that's clear is that ctDNA, this is a tumor-informed biomarker in this setting, is quite prognostic, if nothing else. It clearly distinguishes patients who have poorer outcomes from those who do better. And it seems to reflect some residual disease after cystectomy, which is pretty intuitive. But one of the signals that's really important here is that the folks who received atezolizumab with ctDNA positivity clearly experienced a benefit in disease-free survival based on this reanalysis. And this is an overall survival reanalysis. Again, this is not a randomized trial. This is a reinterpretation from this IMvigor10 study. And what you can see here again is that adjuvant therapy for folks who have detectable circulating tumor DNA is really seems to reflect a benefit for adjuvant therapy. It's pretty exciting because we know that with adjuvant therapy, we're delivering a lot of therapy to some patients who don't have any cancer. All these patients have no evidence of disease at the time. They just have a risk of recurrence. And so the idea of being able to parse out residual disease and hopefully make sort of the idea of adjuvant therapy a little bit to move past that is a really exciting thing, I think, for patients, hopefully minimizing over-treatment of patients. These results have led to the development of a new study, IMvigor11, which is a biomarker-driven randomized trial to administer atezolizumab for ctDNA positive patients. So to try to validate these in a prospective fashion. And this is not, I know this is a busy slide, but this is not meant to be read, just as a reference for anyone who's interested. So this trial is ongoing, and it's very exciting. And many of you who treat other cancers will know that there are really good data for similar biomarkers, circulating tumor biomarkers, now in colorectal cancer and lung cancer and several other cancers. This trial has a disease-free survival primary endpoint, and I do want to touch on that a little bit, because the right way to answer this question is a prospective clinical trial. That is the gold standard therapy gold standard approach to answering a question like a therapeutic intervention like this. But clinical trials, as many of you know, have significant challenges and are difficult to conduct. They're quite resource intensive, and they do face challenges for accrual of patients and completion within certain time points. And so I did want to talk about one particular challenge with these is endpoint selection in clinical trials. So surrogate endpoints have been a bit of a topic in clinical trial design and implementation science over the last 10, 15 years or so, at least. And just to define the term, surrogate endpoints are outcomes that themselves are not known to have a clinical benefit, but are thought or known to predict an outcome that has a clinical benefit. So they do not themselves carry a lot of meaning. They carry meaning because we think they're related to something that carries meaning. Does that pretty reasonable? So they're used as a substitute, and they're thought to predict clinical endpoints. And they're increasing in use. They're becoming more and more frequent. I really like this study from JAMA Oncology, which tracks the proportion of randomized clinical trials. And these are endpoints that are used in various clinical trials over time. And you could see that overall survival is the most common clinical endpoint. And then you could see that it's kind of falling out of favor in randomized trials, while progression-free survival, for example, is becoming more and more popular in randomized clinical trials. And I think not uncoincidentally, industry funding is also significantly increasing in these studies. And what the study concludes is that the use of progression-free survival is increasing. Progression-free survival is more likely to be a positive trial if you use PFS rather than OS in a clinical trial. And it's becoming, like I say, it's become the major, most common endpoint used in clinical trials now. So why should we be worried or cautious about this trend? Well, the assumption when a surrogate endpoint is used is that there's some cause for the patient's illness, their malignancy. We detect some surrogate endpoint like progression-free survival, and that in turn leads to a clinical endpoint like there's the patient's overall survival. But as we all know, that this causality scheme, this causation scheme, is not always quite as direct. Cause can be related to the endpoint in multiple different ways. And so we really have to be kind of cautious about assuming this level A. And there are ways to validate surrogate endpoints. People have done this in the past where we can look at clinical data and try to make sure that the surrogate endpoint is truly causally linked or significantly predictive of a clinical endpoint. And the answer seems to be it kind of varies whether or not a surrogate endpoint is linked to a clinical endpoint. It varies based on the cancer and the specific clinical details. So this is another paper that looked at the meta-analysis of surrogate endpoints in various trials. And it's not always the case that they do predict the clinical endpoint with reliability. This is a big table. I'm not going to go through all of the, not meant to be read, but just to say that this meta-analysis looked at multiple various trials in the past in areas of medicine where we used the surrogate endpoint, and we found that when the clinical endpoint was measured, we really did ultimately find that they were not predictive of each other. And I think one really telling example of this is the CAST trial. So this was a trial in cardiology which looked at patients who had experienced myocardial infarctions in the past, who had experienced intermittent ventricular arrhythmia. And the common thought prior to this publication of the study in 1991 was medications, antiarrhythmics that decrease ventricular arrhythmia would also decrease the risk of sudden cardiac death in patients. And so these were quite commonly used at the time until a pretty heroic, I think, and really brave study was performed. This CAST trial was published in 1991. And what they found was pretty striking. Patients who received placebo did significantly better than patients who received antiarrhythmics in the post-MI period. In fact, mortality was almost double in the patients who received the intervention arm. And as I was learning about this trial, I read an editorial by a cardiologist who was reflecting on this and said, most Americans can remember where they were when President Kennedy was assassinated, and every cardiologist can remember where they were when the CAST trial was published, because it was really striking. And it sort of highlights, I think, the importance of validating any assumed benefit from surrogate endpoints. So people have tried to do this, and like I say, it kind of varies. So this is, again, a big trial, a big table, not meant to be read here, but what you can see is that whether a surrogate endpoint is helpful depends on the setting. So multiple studies have shown that progression-free survival in advanced or metastatic colorectal cancer is a reasonable surrogate for overall survival in many of these trials. Whereas in breast cancer, it seems to not be a good surrogate. And it has to be done on an individual basis for each cancer, for each stage. It's really quite important work because we rely on them significantly. This is a paper demonstrating how much we rely on them. This is a paper published in JAMA in 2020. And what they demonstrate by evaluating FDA acceptance based on surrogate endpoints is that the use of surrogate endpoints is increasing, like we talked about, and 61% of new medications that are approved based on surrogate endpoints are based on endpoints that have not been validated or lack correlation studies. So we really don't know if the surrogate is related to the endpoint we really care about, which is making patients live longer or making patients live happier, healthier, or lives that have better quality of life, I guess. 61% of the time we don't have a link. 16% of the time we use them despite data demonstrating a poor link between surrogate endpoints and overall survival. And only 5% of the time is there an established high correlation. There is a post-marketing requirement for medications that are approved based on surrogate endpoints. And this paper demonstrates that upwards of a third of trials don't report within the time period. So in bladder cancer, we do use surrogate endpoints quite a bit. We rely on them really heavily. Here's an example from bladder cancer, which we won't go into a whole lot, but this is a paper published in 2017, which is a single-arm phase 2 trial that evaluated atezolizumab in a very difficult population. This is cisplatin ineligible patients in the second-line setting. This was about 119 patients were enrolled, 102 of them discontinued therapy because of progression, and objective response rates were in 23% or so at a median follow-up of about 17 months. So this wasn't a home run thing. This wasn't. This was a signal in a difficult population, and it resulted in accelerated approval by the FDA for atezolizumab in this setting. And this is just as an aside. Multiple cost-effectiveness analyses of this drug show that it's really quite costly to administer. Upwards of $400,000 per quality-adjusted life year for atezolizumab in this setting. And we learned about 5 years later that it was withdrawn, and it was withdrawn because the final data reported out that overall survival benefits were not detected in this setting. Now, some might say, all right, well, that's showbiz. That's the cost of it. Sometimes you approve drugs and you give patients drugs that don't do that much benefit for them, but at least they get them faster, And what I would say is that the effect can often be more widespread than we really think about, or at least than I think about. This is a paper that was published by the folks at the University of Pennsylvania, which evaluated the Flatiron database, so kind of a large national database for patients who are exposed to cancer medications that were then ultimately withdrawn. And what they find is that it takes about 46 months from accelerated approval to withdrawal. So it's not a huge time period, but it does result in approximately a quarter of patients with cancer in the United States getting exposure to therapy that ultimately is demonstrated to not be beneficial. And in bladder cancer, it's about 22%. So it's a significant number of patients. And this is an interesting editorial. This is an editorial, it's a letter that talks about what the global impact of this practice is for other countries, especially low and middle income countries. And here, the group, Bishal Ghali's a medical oncologist who writes and thinks a lot about this problem. And he highlights that oftentimes other countries, especially low and middle income countries, will approve medications based on FDA recommendations. And so the FDA approves these medications conditionally. They're accepted as FDA approved medications in other countries. And then if they're withdrawn in the United States, they continue to be approved in these other countries. And in fact, are often continue to be marketed in these other countries for the indications for which they're withdrawn here in the United States. And that's a really striking fact. These are long quotes, but I think it's worth just looking at. This is from the paper. Thus, once a drug is approved by the FDA via the accelerated approval pathway, the drug can be marketed and promoted in low middle income countries as an FDA approved drug. And then confirmatory trials confirm they're negative, and these are not communicated to those same countries. And this is an example again from, in this case, atezolizumab, which I've highlighted multiple times now. But immediately after the drug's withdrawal from the market, the company issued letters, in this case to India, stating that atezolizumab would continue to be marketed in that country. And it's not just this country or this medication or this company, but this is they show 9 other examples in this paper. So My point in all of this is that this is a practice that has some real downsides, should be really thought about carefully. And of course, many people are thinking about it carefully, but does have global implications. We wanted to look at what some of these surrogate endpoints, how they behave in bladder cancer, because again, that's been my main interest. And so we took a look at this. We looked at the relationship between commonly used surrogate endpoints and overall survival in metastatic bladder cancer. And the methods were pretty straightforward. We just did a review of clinical trials in bladder cancer. We looked at progression-free survival and response rate and some other information, and determined how effectively it predicts overall survival. So this is a big table. We looked at all trials, which were 62 trials, and split them up into immune checkpoint inhibitors and non-immune checkpoint inhibitors. And we can skip through some of this, but you can see that the immune checkpoint inhibition trials were performed, the median year of publication was later than the chemotherapy trials, and tended to have much larger Ns compared to non-checkpoint inhibitor trials, which we can talk about why that matters. And we reported this earlier this year. The first thing you can do to try to understand sort of how well these two, a surrogate endpoint and a clinical endpoint, relate is you can ask, well, what is the R-squared coefficient for the hazard ratio for progression-free survival compared to overall survival? And you can see here that in this case, it was pretty reasonable. It was about 0.6. So it's not a strong predictor, but it's not strongly correlated, but it's I would say moderately correlated. One can ask a second question, which is, what it's a metric called surrogate threshold effect. And what surrogate threshold effect is what result from the hazard ratio of progression-free survival do you need to see to give you 95% confidence that it's going to reflect an overall survival benefit? So you observe the surrogate, and it gives you, with 95% confidence, an OS benefit. And so what would that number be? And so that turns out to be pretty straightforward to actually calculate. The first thing you do is you get 95% predictive sort of confidence interval around your correlation line. And then you want a value that is below 1. And so you see what hazard ratio that for progression-free survival that number intersects at. And for bladder cancer, we found that R-squared was 0.6 and the surrogate threshold effect was 0.41, which means if you want 95% confidence that the OS is improved without observing it, you should see a PFS of 0.41. It doesn't mean that you need to have a 0.41 PFS to have an OS benefit. It just means that if you're not going to measure OS directly and you want that confidence, that's the value you need to get. We did the same for objective response rate here. And what you can see is that for hazard ratio for objective response rate, it actually never hits that 95% confidence interval line. So for that, our R-squared was 0.03, and our surrogate threshold effect was not reached. It wasn't calculable. And so from this study, we sort of conclude that surrogate endpoints are poorly characterized in bladder cancer, and there's sort of a weak to moderate correlation for progression-free survival, but really quite a poor correlation for response rate or tumor shrinkage on cross-sectional imaging. And so we really should be de-emphasizing response rate, we conclude, as a primary endpoint when possible in metastatic bladder cancer clinical trials. More broadly, I think outside of bladder cancer, sort of zooming out again, the question of clinical trials, we've seen this trend of clinical trials changing pretty significantly, and it's responding to a lot of pressures. And, I'm not under the impression that this is an easy thing to do. But when you think about the major stakeholders in clinical trials that are involved in bringing a new medication to patients, you think about the FDA, you think about the pharmaceutical industry, you think about the patients themselves and patient advocacy groups, and then physicians. And, I'm happy to have a longer discussion about this if people are interested. But I think that if you look at each of these factors individually, I think that the onus really is and has to be on physicians to protect the scientific integrity of clinical trials and make sure that we're really cautious about some of these things. I think while all of these other factors are key players in bringing medications to patients, really we are the ones who really are, I think, best equipped, and the onus really falls on us to think about how to do this and protect patient clinical trial integrity. So this is the thing I'm interested in, and I'd love to, many of you have thought about this, of course, and a lot of academic scholarship about this here at Yale. One of the first things I did when coming here is I connected with the Copper Center and contacted Mike Leapin and Carrie Gross and reached out to him because Carrie Gross has, of course, written quite a bit about this and thought deeply about a lot of these problems. And so we have started to work together a little bit on some projects that look at topics related to this. And I also wanted to highlight one other organization with many of the folks that I referenced in these other papers, Christopher Booth and Bishal, who's also a part of this. And this is not an organization I'm a part of, but they did start a program called Common Sense Oncology, and it's for physicians primarily who are interested in taking on the role of thinking about this and moving, I would say, the conversation to talking about endpoint design, the appropriateness of crossover in clinical trials, and some of the implementation science around clinical trials. So just wanted to make people aware of that. So in conclusion, there's a lot of important work to be done in bladder cancer, as I hope I've highlighted. There's a lot of room to continue to improve patient care. I think that urinary DNA has a potential role in that future. We have very early data, and there's some more robust data out there, and we're hoping to continue to work and validate this as a biomarker in both early and late bladder cancer. We need to be giving more chemotherapy in bladder cancer. We need to be giving more chemotherapy for patients undergoing surgery and for folks undergoing radiation, and I hope I showed you some data to convince you of that. And finally, clinical trials are key. They're really important for patients, and especially in bladder cancer, we've seen tremendous work and really exciting data of late, especially. But I think it is the role of physicians really to ensure the integrity of the scientific endeavor that is a clinical trial, and design answers that really focus on questions that are meaningful for patients, making them live longer, improving their quality of life. Thank you very much for your attention. I'm happy to chat a bit and answer some questions.
Thank you, Dr. Ghali. Any questions, audience, from the internet? Very good. Maybe I will start for questions. So it's very beautiful talk about the urine DNA, how it's being used for non-muscle invasive bladder cancer, and some work you did in terms of visibility. And you also mentioned about the low sensitivity and the low yield. In a way, it sort of makes sense because it's very superficial disease, very low volume of disease. I wonder if you can share any data or any insights on using that in muscle invasive disease. Maybe this is better setting to use that in muscle invasive setting. Mm-hmm. How we can monitor treatment response to neoadjuvant chemo or even chemoradiotherapy as well.
Yeah. Yeah. There's a couple of questions I think when asking what its role what a marker like this, what role it would play in muscle invasive bladder cancer. I think the first obvious thing for me would be to ask for folks who receive chemotherapy and have a really strong response, can we identify patients who are completely responded to chemotherapy, and we can maybe de-escalate their therapy and identify them for not having radical cystectomy? Right now, people try to do this with cytology or bladder biopsies, and it has reasonable sensitivities, again, somewhere in the 80% or so. But if you're going to forego cystectomy, you would want to be really sure that there's no residual cancer, because being wrong about that has a real high cost, I think, for patients. And so I think that that's one real exciting place. And I don't have any data here to show you, except to say that we can definitely detect tumor-associated DNA before chemotherapy, after resection, but before chemotherapy. So those dynamics are at play, and we have seen decreases in that number with chemotherapy. But I've only looked at about 10 patients or so. So not enough to be able to say, yeah, we can start eliminating cystectomy in some of those. But I think that would be a key question. Yeah.
Thank you. We should definitely do this study here as well.
Yep.
Any other questions? So maybe I can ask another question about this. So with that design, what will be the adequate endpoints? You talked about endpoints in metastatic setting. Mm-hmm. We talk about the endpoints in non-muscle invasive disease, muscle invasive disease, with the introduction of this novel biomarkers. What do you think will be adequate endpoints, mm-hmm. in studies like that?
to start a study like that would have to be a prospective observational study. I think I would start with urine collections, data analysis, and then undergoing radical cystectomy. And the main endpoint I would look for is pathologic complete response. And the reason I choose that is because I didn't share it here, but from that 2003 paper with Grossman et al. That first showed us the benefit of MVAC in muscle invasive bladder cancer, but multiple other papers have shown that patients who have pathologic complete response on surgery do significantly better. It's a really nice surrogate. So this kind of ties back to how we ended the talk, is that surrogates aren't all bad. It just has to be a validated, useful surrogate. And I think pathologic complete response is one of those. So that's how I would do it to start. And then ultimately, I think the goal would be a prospective study where you identify patients who sort of are positive and then become negative after chemotherapy. So you biomarker select them into a study, and then you would randomize those patients, or at least, that's a tough thing to randomize to, but you would, as much as you can, offer patients multiple arms to treatment or no treatment, and then observe quite carefully afterwards. But we would need, I think we'd need pretty good data before we would withhold surgery for patients in this setting. I should say there's a study out of Fox Chase that is doing this. There's the RETAIN study that's looking at de-escalating therapy, and it'll be exciting to see the results. But we have to be really careful, I think, in these patients, because it's a bad disease if we miss a window.
It's a very life-changing treatment too, especially with the cystectomy as well.
Yeah.
Thank you. Any other questions? Any questions from the online?
Do new therapies replace chemotherapy, give up chemotherapy? So yeah, that's a good question. I think bladder cancer has seen, I think like a lot of solid organ malignancies, has really seen kind of a revolution in how we treat it in the last 10, 15 years. We've seen the importance of checkpoint inhibitors. We have antibody drug conjugates and several other important classes. And I have seen, a lot of these medications move earlier and earlier in the treatment paradigm. Cisplatin is really quite a useful drug, I think, in bladder cancer. And Dr. Kim, of course, could probably speak about this much more than I could. But I don't think that we'll ever be at a phase where, or at least not anytime soon that I can think of, where chemotherapy has no role. But no doubt, checkpoint inhibitors and these other therapies are definitely moving earlier. I think they're going to play a bigger and bigger role in bladder cancer patients. We just, I think for the first time, saw data that there's an overall survival benefit in the frontline setting to a regimen that isn't cisplatin based. So we beat cisplatin in the first line setting for the first time with a combination of enfortumab vedotin, which is antibody drug conjugate, coupled with pembrolizumab, a checkpoint inhibitor. So those two agents, and it's a big deal. We've been using cisplatin for decades now, and so it's proven a really resilient regimen. So big news.
Yeah, they had a standing ovation at the ESMO meeting.
Yeah.
All right. Good again. Thanks, Dr. Ghali, for your fantastic talk.
Thank you.
Thank you.
Yeah. Thank you.
Good.